Well, hello, everybody. Hi and good afternoon, good morning, depending on where you are. My name is Garrett Schmidt, and I am the managing editor for VBC Exhibit Hall. And I'd like to welcome all of you to today's live webinar hosted by Healthjump. And it is called How Harnessing Healthjump's EHR Data Results in Time-Saving for Practices. It's a mouthful for me, but we have some really great stuff. I got a sneak preview of what they're going to be covering today, and I think you're really going to enjoy the presentation. A few items of note before we get started. Everyone's joined today in listen-only mode. It's a traditional webinar format, so we can't see you or hear you, but we do want to hear from you. So please ask some questions if you have any for the team, and we're going to have a Q&A time toward the end. We're going to get to as many as we can. So please go ahead and ask yours at any time. You don't need to wait until then to do it. You have a little control module that has a questions space on it. So go ahead and ask it there, and then we're going to get to, again, as many of them as we can. If we don't get to yours for some reason, someone will reach out via email to get an answer for you. And then finally, today's session is being recorded. So you're going to receive an email from me afterwards, and maybe an hour or two after the presentation, and it will have a link to the recording and to where you can download the slides and some other information for you, how to get in touch with the team. So keep an eye out for that as well. So without further ado, I'm going to hand it over to Miss Laura Stewart, and she is the Director of Product Delivery with Healthjump, and she will introduce our other speakers today. So welcome, Laura.
Great, thanks, Garrett. And thank you everyone for taking time this afternoon and morning to spend some time with us today. We are going to cover a little bit about the story of Equality Health and Sun Lake's family physician partners and how we all work together. It's my great pleasure to introduce myself. Like Garrett said, I'm Laura Stewart. I'm the Director of Implementations at Healthjump, and I live in Kansas City with my two cats and my husband. We're kind of weekend warriors, so we do a lot of projects and renovated a pretty old home and worked on 3 vintage cars in our spare time. I also have 2 other fabulous leaders in healthcare with me on the phone today. First up is Claire Zimmerman. Claire is the head of product at Equality Health. She's definitely an industry veteran, and I think you'll really enjoy hearing from. And she lives in Phoenix with her husband and beautiful daughter. Equality Health partners with Sun Lake family physicians. And so we also have Nikki Smith, one of the leaders from Sun Lake Family Physicians with us today as well. She's been with her practice over 16 years. She also lives in Arizona and enjoys taking advantage of all the beautiful stuff they offer her husband and 3 children. So before we dive into the questions, Nikki and Claire, would you share a little bit about your guys' partnership together and about your organizations?
Yeah, absolutely. Nikki, I'm happy to kick it off if you'd like, and then give you an opportunity to spend a little bit of time talking about Sun Lakes. So just want to echo Laura's thanks to those who've joined us either this morning or who view the recording at a later time. As Laura said, my name is Claire Zimmerman. I lead product for an organization called Equality Health based here in the Phoenix metro. Equality Health set out 6 or 7 years ago to support primary care providers who are independent today, want to stay independent, but are increasingly sort of struggling to see a path to independence in an environment that is holding them increasingly accountable for outcomes. We'll talk about this a little bit later as we get into the session, but it's a tricky time to be a primary care provider. That was true pre-COVID, and it is more true post-COVID for sure. And so Equality Health offers a model to primary care providers where they can continue to stay independent, keep their own name on the door, continue to run the day-to-day operation of their practice as they do today, but they partner with us on their value-based programs. So we administer the value-based arrangements between these practices and our health plan partners, and we support our primary care providers with data and tools, and in many cases training, to help them make sense of a value-based environment, and we incentivize them to do the work that we believe will ultimately lead to improved performance in value-based contracts. It's my great pleasure to be here today with Nikki Smith, who's the practice manager at Sun Lakes Family Physicians, which is a longtime partner of Equality Health. We've been working with Sun Lakes for a number of years, and we truly believe that they are best in class, delivering best in class primary care to members of our community. So, Nikki, I'd like to just give you an opportunity to talk a bit about Sun Lakes, if you wouldn't mind.
Yeah, absolutely. So like Claire said, well, first of all, good morning, everybody. Well, it's morning here in Arizona. Good afternoon to a lot of you. We have been in partnership for many years, but Sun Lakes as its own entity was established here by 3 providers in 2001. 2 of the 3 founding physicians are still in practice here. We serve a geriatric community here in Sun Lakes, which is a retirement community, but just like most of Arizona, it's growing far outside what anybody could have imagined several years ago. So we've gained more than just our seniors. So we've become a resource for all ages, mostly 18 and up. But we value our independence and would like to continue that way. But yeah, it takes a village to be able to report all the things and understand everything that needs to be sent in, and we enjoy our relationship with Equality and keeping us up to par. So yeah, that's a little bit about us.
Thank you both.
Yeah.
I definitely agree with you. There are so many challenges today that didn't exist a decade ago. Do you mind kind of sharing from an Equality Health perspective, Claire, what challenges you're seeing with the practices you work with, and maybe some of the things you're doing to address them?
Yeah, absolutely. Happy to. And my response to that will come in 2 parts. The first is pre-COVID, and then the second is post-COVID. And as I mentioned before, I think it was difficult to be an independent primary care provider, even in a pre-COVID environment. We partner with primary care practices, 60% of whom believe that the shift to value-based care will have a negative impact on their practice overall, be it their finances or the way that they run their operation. And we work with those practices to help them see a path to financial sustainability in an environment that is holding them increasingly accountable for outcomes. And there are a lot of reasons why it's difficult for, in particular, smaller independent primary care practices to be successful in a value-based arrangement. One of the big ones is just access to good data. We partner with practices who, on average, take about 12 different value-based arrangements with 12 different health plan partners. And I should say up front, I spent about 7 years with a health plan before coming to Equality Health, and with the best intentions, we deployed value-based programs that were very specific to us, with data sets that were very specific to us, and portals that were very specific to us. And we believed that they were best in class, but having come to Equality Health and having spent more time with Nikki and others in the primary care setting, I now appreciate the fact that we were one of 12 health plans who had disparate asks of the primary care provider, who sent different data, who, sent representatives into the practices with spreadsheets or CDs or what have you, and asked for a very specific set of activities. And if I'm Nikki, I'm sitting there saying, I don't know what to do with any of this. My providers are seeing 30 patients today, and I don't know how to change the way that we do things to then map to what the payers are asking us for. And the arrangements that I'm on, I don't understand. I may or may not get a check at the end of the year, and I have no sort of understanding or foundation for why I did or didn't earn a check at the end of the year. And so I'm just going to keep doing what I'm doing and hope that there's money on the other side. So you can start to understand why As I said, 60% of primary care practices are saying, like, I don't know what to do with this, I don't trust it. And as a function of that, you can see on the right, we're expecting a material shortage of primary care providers in the coming years because those PCPs are saying, this isn't worth it for me anymore.
Right.
So that's all pre-COVID. And then you add in COVID and sort of what it's like in a post-COVID environment, where, you know, every practice we talk to in the market talks about the fact that it's hard to get schedulers and medical assistants. It's hard to keep schedulers and medical assistants. Practices are sort of working to reinforce the need for preventive care, with a patient panel who just got used to not going in for prevention for a period of time. And so, you know, you add in post-COVID staffing shortages, post-COVID sort of shifting of relationships with patients, and it's hard for independent practice to be tenable for primary care providers in the current environment. And a ton of that is just due to not healthcare delivery. It's not healthcare delivery that is that much harder. It's not population health interventions at their core that are harder. It's the administrative burden associated with these programs, right? It's the, okay, I'm seeing Jane Doe today. She's a UHC member or an Aetna member, and therefore I have to do these things. And then at the end of the visit, I have to remember to go upload those things into a portal. It's all of the work around the actual visit that is burning practices out. And so at Equality Health, our mission is to make all of that easier. We do that through proprietary technology. So we have a population health tool that we call Care Empower, which is multi-payer. So for practices like Sun Lakes who participate in multiple contracts with us, they log into Care Empower and they see their full panel of members in one place with activities in black and white that are consistent across patients that we are trying to sort of drive in practice, regardless of who the health plan is. So whether it's Health Plan A or Health Plan B, we're looking for the same set of preventive activities to be done during the visit, the same set of referrals. We're asking for medication adherence the same way, whether it's Health Plan A or Health Plan B. And so in all of this, we're sort of working to minimize the administrative burden and the chart prep burden and the sort of documentation burden associated with value-based programs that are causing such problems for primary care providers.
Yeah, which in turn, Claire, when Equality Health helps take us that administrative burden away, it allows us to make patient care our #1 priority again. And when you value that so much and you're trying to make patient care your #1 priority, but the administrative burden is so high, it takes some of that away.
Yeah, it's a great point.
Yeah, absolutely. I know when I was at an EMR vendor prior to coming to Healthjump, working with, you know, ambulatory practices, one of the challenges is, you know, not every system out there from an EHR perspective looks the same, records things the same, and certainly doesn't store data the same, unfortunately, which makes some of the data pieces very challenging to kind of bring it all together in a systematic way. Claire, could you kind of walk through what you guys are doing with us at Healthjump to fulfill some of those data needs, to provide those tools and services to practices like Sun Lakes?
Yeah, absolutely. So we convened a group within Equality Health about a year ago and said, okay, it's hard and getting harder for our primary care providers. We are hearing it from our partners every day. And so we need to do more to help alleviate the strain on our primary care providers so that they, to Nikki's point, can continue to deliver high quality care and stay independent if that's what they choose to do. And so we had a discussion internally about, like, okay, what value add work are we asking our practices to do today? And what work are we asking them to do that's not terribly value add at the end of the day? What can we take off their plate so that they're not having to spend so much time on the administrative side of healthcare? And where we landed on that was, we think that there's a ton of value in driving proactive information into the practice to help inform who gets seen in the practice and to help sort of bridge the gap in preparing for that visit. Because we all know that, patients are bad historians, right? I'm a bad historian when I go to the doctor, and I have no excuse to be. And so where we landed was we can add value in pushing additional information into the practice to help inform the visit. The thing we're doing that's not super value add and that is burdensome for our practices is we're asking for a ton of documentation on the back end. And this is, by the way, a super common workflow that exists in these value-based programs today, where it's like, hey, after you do the visit, like, we would like a copy of your chart. We would like you to let us know what things you did as part of that visit so that we can, pay an incentive or update our coding accordingly or pick your favorite thing. And we just said, that's something that we can reduce the burden of for our practices, not adding a ton of value for them, not necessarily adding a ton of value for us. And so we partnered with Healthjump to say, how can we get access to the data that is in the EMR that would tell us, without having to ask, whether the activities that we're asking practices to complete as part of these visits are actually getting done? How can we use this data that's available to reduce the burden of sort of clicks in a population health application or the upload of a chart, so that we just know what's going on? And how can we then use that data to be more proactive in identifying gaps or needed next steps, using data that's more timely than claims will ever be? And so we've been working with Healthjump for about a year now to onboard, to integrate with the dozens and dozens of disparate EHR configurations that exist in the network, and to share that data back with us, both clinical notes and increasingly things like scheduling data, so that we can be more, we can add more value for the primary care practice, both in reducing administrative burden, but also in proactively sharing information, so that Nikki doesn't have to go in and say, well, I'm seeing these 13 patients today, so let me go look up their details in Care Empower. We know who Nikki's seeing today, and we can say, hey, Nikki, here's information that might be helpful for you today as you do your visits. So we are just, I'll say, scratching the surface in terms of what we could do together. But we're super excited about the results and super excited about the future of the partnership and the value that it can drive for our primary care partners.
Yeah, absolutely. And we are here too. Outside of that, just for the audience on the phone, Healthjump has over 60 EHR systems that we kind of support out of the box. And so when we work with Equality, they come to us when they want to set up a new practice. We will get connected to that, whether it's a direct to database implementation or if it's a cloud EHR vendor through their APIs, and pull data pretty immediately. That's kind of one of the things we pride ourselves in, is quick access to data, so that speed to value is really there for our customers and the programs that they're driving in the value-based care space.
Yeah, and saving time submitting that supplemental data on the back end, it's immeasurable how Healthjump just takes that information, provides it, and it saves our staff a lot of time.
Yeah, it is immeasurable. Having done that on the other side, the supplemental data it's very tedious. You kind of don't know what to expect each time it comes around. So absolutely. Are there things you guys are doing to identify and address the needs of high-risk patients in your community with the data?
Yeah, absolutely. So as part of the workflow that we deploy in Care Empower, which is our population health tool, we're supporting our practices in sort of driving better understanding of who the most acute patients that they're seeing are, and recommending a next step. Like, this person may be due for a primary care visit. offering options for them to refer those members to our staff in the field to get some additional support, et cetera. I think the limitation of those models, whether it's related to the identification of a high-risk member or the sort of suggestion of what needs to happen next, is it's all based on claims data historically. So in many cases, these, particularly for the population that we serve, that's predominantly Medicaid or Medicare, the exacerbation for these patients happens quickly enough that claims oftentimes will not catch them. And
Right.
so we don't want to be in a situation where Nikki is telling me like, hey, here's a high risk member that you guys totally missed. And so the value of having more timely access to information through our Healthjump connections, through connections with like health information exchanges and real-time lab feeds, is we can more proactively identify those members who are at risk of some sort of acute event in the very near term without waiting for claims to tell us that those activities have already happened. So there's a ton of value to be unlocked there. And then, and Nikki, I don't want to speak for you here, so add color if it makes sense. But I think the other thing is, then as those patients are coming into the practice, like just having better, more timely visibility into the fact that, they had this event last week and we know about it now and they aren't taking their medications, like to the point of, all patients are bad historians, but particularly those who have the most acute needs, we can sort of de-risk some of that patient history by providing more timely information.
Yes, exactly. So we have in our senior community a lot of high-risk patients, and identifying them is, troublesome enough, but identifying them in a timely manner when patients are constantly falling into that denominator or category, and we don't know unless they call in and tell us, so and so such and such happened. So identifying them real time is incredibly helpful.
I think the other factor, and we could talk about this more broadly than just in the context of high risk patients, but the other factor at play, particularly in 2023, is Medicaid redetermination and the end of the public health emergency. So the population that we're talking about here that has the most acute needs is likely also the population that will struggle with a sort of Medicaid renewal process because they're hard to find in the community, don't have super great health literacy, et cetera. And so all of that is resulting in just a ton of churn in Medicaid eligibility these days. And so all the more reason that you can't wait 90 days for a claim and hope that at the time that you would get that claim that the member does have current eligibility. Like those two factors have to move in conjunction with one another. And there are a ton of gaps in data right now as a function of redetermination that I think to a large degree, just having more timely access to data can really help mitigate.
Yeah, absolutely. For sure. As we kind of talk about, high risk patients and redetermination, I think another factor that kind of plays into, helping a lot of those patients is there's a health equity strategy there too. Can you kind of walk us through what your kind of strategy around that is and how equality tries to tackle that, Claire?
Yeah, absolutely. So health equity has been a part of Equality Health's mission since its inception. That is both missional for us, but also critical given the population that we serve, Medicaid, Medicare beneficiaries, in a pretty diverse area. And it seems like over the last, let's call it year, this concept of health equity and social determinants of health is really coming into vogue, which we are very excited about because it's been something we've been working on from the beginning. When we think about our approach to health equity, I think the first step is just to understand where the disparity is. And I'll say the healthcare industry's data infrastructure, which is typically driven largely by claims, is not set up well to create visibility around, you know, not this person has diabetes and their labs are out of control, but this person has diabetes and their labs are out of control and they're not taking their medication because they don't have food in the house to take with it, and they can't get to their doctor because they don't have adequate transportation. Like, all you would see in claims is that that person has a diabetes diagnosis. You wouldn't see any of the underlying sort of the iceberg below the surface, if you will, of, you know, all of the reasons and the confounding factors that diabetes is out of control. And so we're working really hard to first and foremost understand the disparity that exists in our population, and to create visibility for primary care providers into that. And data is a key component of that, right? We can't build an intervention around something that we don't understand. And we don't candidly really want to put the primary care provider in a position of having to ask all of those questions in a 9-minute visit and then report it back to us. So the more information that we can get from, again, any and all data sources, including the EMR, without having to ask for additional documentation from the primary care provider, that's really critical for us. And then increasingly, I think anybody who's participating in ACO REACH or has seen maybe the new HEDIS measures that are proposed in the coming years can attest to the fact that it's not only important to have that data internally, but it's almost the same supplemental data conversation again, which is increasingly CMS, health plans, and others are asking for this data related to race, ethnicity, language, socioeconomic factors, gender identity, any of those things. And so Healthjump has been a really critical element of that strategy for us as well, because we believe that our providers do a pretty good job of capturing that information. And the sort of healthcare, the traditional healthcare data infrastructure is just not like set up to collect it en masse. So that's been a really important part of our strategy.
Yeah, I completely agree with you. The data infrastructure comments, and it's there. It's finding it so that you can actually do something with it and make a difference. So very, very good highlights there. Do you mind sharing some of the successes that you achieved in 2022?
Yeah, absolutely. So I mentioned we've been working on our partnership with Healthjump for in the neighborhood of a year, something like 9 months now. Big push at the outset to get as many of our practices integrated as we possibly could, because we wanted to be able to implement some of the workflows that we've been talking about. And I just want to thank Nikki and her practice for having been an early adopter in that process. We're fortunate today that we're approaching 50% of the attributed lives in the Equality Health Network are with a practice whose EHR is integrated through Healthjump, which is a really exciting milestone for us. Now, that's not to say that we don't have more to do. We absolutely have more to do with our smaller practices or practices that are on, you know, maybe legacy EMRs or what have you, but we're really excited to be approaching that milestone and think that it's just the beginning. The one that I'm super excited about is the middle one here, which is the degree to which that even phase 1 implementation has saved time for our practice partners. 1,000 hours of work in a practice that has a handful of physicians, like, that's not insignificant. That's in a world where, you know, it's hard to keep a medical assistant beyond their first week. The ability to avoid 1,000 hours in administrative burden is a big deal and something we're super excited And we want to keep sort of driving that number down and down so that we can really work with practices, to Nikki's earlier point, to focus on better patient care, which is, I mean, what are we all doing here if not that? And
Right.
then, you know, and this is both a function of just, you know, the sort of scale of the Equality Health Network and the work that we're doing with our practice partners, but also a function of the work that we've been doing with Healthjump, which is, you know, across our network in Arizona and other markets, we're closing north of 1 million gaps a year for these patients, whether those are preventive screenings or adherence issues with medications or referrals that need to happen out of the primary care office. Like we're really starting to move the needle on these gaps in care that ultimately, you know, impact a patient's health. And so we're super proud of that. But as I said, the one that I'm most excited about for our practice partners is the reduced administrative burden for our practices, because that's really that's our commitment of value to them, is that we will make this easier for you. So to see us moving the needle in that space, I think has been really exciting for all of us.
Yeah, that's definitely proven to be true, not only with the reporting of the supplemental data on the back end, but on the front end with chart preparation. It saves time there, and with just the sheer number of payers that fall under the Equality Health umbrella, so we can find all of that real-time data in one place with so many payers.
Yeah, that's fabulous. And yeah, that's a staggering number in terms of success, and making a big difference to, you know, a small practice in terms of savings. That's time people get to spend with their families instead of at night catching up on things or prepping things for the next day. So kudos to you guys. That's amazing. Would you mind sharing kind of what your goals are, Claire, for 2023 in terms of, you know, new features or services or capabilities you're looking to roll out?
Yeah, so the first thing I'll say is 50% penetration with practices in the network is not 100% penetration with practices in the network. So the first order of business is, let's just continue to integrate with additional practices and with additional EMRs so that we can really do this work, continue to do this work at scale. And so we're pressing forward and super grateful to Healthjump for their partnership in that. Then as we think about the data that is coming in the door, right? So that's, how do we scale up the volume of data that's available and the number of practices that we can influence? And then when the data is in the door, what do we want to do with it? We've talked about some of the initiatives that we're focused on today. Big push around health equity, capture of race, ethnicity, language, gender identity data, just as a function of our ACO REACH program, and some of the other sort of HEDIS measures that are coming. So we're really excited about that. But the big one for me is, I want to be doing more than we're doing today with scheduling data. We're scratching the surface today on the scheduling data front, and have been really focused on clinical notes to reduce that burden on the back half of the visit. But I think that there's a ton more that we can do in proactively identifying members who need to be scheduled, but then also in making sure that we have a one-to-one with what's in the practice scheduling system. Like, I don't want our practice managers or our schedulers to be logging into Care Empower and saying like, well, you're telling me that I need to schedule these 5 patients and they're coming in next week, and why don't you know that, right? And the answer to that question today is like, well, we don't have a ton of visibility. But in a world where we have Healthjump data, more robust scheduling data, I can make sure that the information that's showing up in Care Empower matches exactly what's in the practice's scheduling system. And they don't have to then sort of sift through the two or spend any time kind of reconciling those two lists. It'll just be reflective of the work that they're doing and help to prioritize in areas where maybe patients have fallen through the cracks or they have had some sort of exacerbation that needs to be addressed. So scheduling data is going to be a big unlock for us in 2023, and something we're super excited about.
Yeah, absolutely. I mean, there's nothing more frustrating than when technology doesn't sync because it's not all there. So getting that in place, I think your users will really appreciate that and take advantage of it. And I would imagine it will help with adoption as well of the platform.
Yep.
Fabulous. Well, I think we're kind of at the point of letting the audience ask some questions. So Garrett, do you want to queue up some Q&A for us?
Yeah, well, first of all, thank you guys. This was a fantastic presentation, and I think you covered a lot. So I know there's some questions out there. If you have a question that you would like to ask the speakers right now, you can do so using your little control module. There's a place for questions there, so go ahead and drop it in, and we'll get to it. If we don't get to yours for some reason, we'll reach out afterwards via email and make sure we answer your question. So in no particular order, let's start with this one. Can you tell me how long it takes for Healthjump to complete an implementation?
Sure, I'd love to. So I kind of briefly teased it earlier, but we pride ourselves on speed to implementation, and so we do have 60 plus systems that we support out of the box, where we've got standard code that puts data into our standard data model that our customers consume. And so those implementations are pretty quick. From a new customer onboarding perspective, we have a series of onboarding sessions we do with our customers to get the first practice or facility live. And our goal is to take someone live within the first 30 days, if not sooner than that. So if you're ready to go and you have underlying access to the database or can submit the request for cloud credentials, so we can call the APIs, it's real quick to get data flowing. And then from there, we spend time with all of our customers working on questions on the data, consuming the data, fine tuning, going through any questions they have, and then planning out mass implementation. So it's not uncommon for someone to come to us and say, hey, I have 20, 30, 40, 100 practices that I need to get data for in less than 5 months. Can you do that? And their answer is always, yes, we can. Let's sit down and prioritize and devise a plan and hit go. And we've really got it down to science now. That's what we do here every day, all day long.
Great. Yeah, thank you. Okay, second question here is, as the need for data evolves, what is Healthjump doing to support growing customer needs?
Yeah, that's a great question. I know Claire kind of shared, unlocking scheduling data. She also mentioned documents. That's a newer offering that we're offering in our implementation delivery space for our customers as kind of an add-on to our standard data model that they can select at the time of implementation or hook on later down the road. So that's one item that we're doing, and that allows our customers to take progress notes from visits, other documentation, and consume it and use it. In some cases, they're storing it, serving it Facebook on their platforms. In other cases, they're using it to parse things through and their own intelligence on top of it to find things and notes. So there's a lot of use cases for them, and we're seeing a growing demand for that. We also have a lot of customers that want to get data back in front of a physician that maybe don't have a platform that's as integrated as Equality does. They still want to get something in front. And so we have a product that we call Beacon that could get deployed where you can display whatever you want in front of the physician or end user to alert them of, preventative care that needs to happen during the visit, remind them that scheduling needs to happen, whatever kind of information they want to put in front of the user. We also are working on, for some of our value-based care practices, the lab data, specifically the results. aren't always codified in the source systems. In fact, most of the time they're not. And so for the results that are commonly reported on, like A1Cs, EGFR, testing, et cetera, we are working on link code mapping for a customer right now that we're rolling out as a pilot here this month, and then hope to take it GA later this year as well.
Great. Okay, next question here is, we've had really bad experiences in the past with vendors' data quality. How do you ensure data quality?
Yeah, I think anybody that's played with data over time has probably had that experience. I've had it too. So it's a concern that I have every day, making sure that our team delivers high quality data at Healthjump. So we have a set of automated scripts that we run against data when we do initial data ingestion in terms of historical data. Most of our customers ask us to pull a backload of data for a set number of years or for all our time. And we run those scripts to make sure that there's nothing wrong with the extraction. Like maybe the practice could be documenting something a little bit differently than every other practice we've seen. Practices, and a lot of systems have the ability to flex and, create their own templates and forms and things like that. So we want to make sure we're actually capturing the data that we should be capturing and that the data is high quality. And so we run through that routine. We will connect back to source, poke around, make sure everything looks good if anything falls out of the QC checks. And we also have a set of scripts that we use to kind of inform our customers that are consuming the data of maybe practice things that they might be doing that aren't quite right. So, some systems will allow someone to enter, a resolve date before an onset date or things like that for dates and things. And so we want to track and trend those things too, so we can inform our customer and the practice that they might have some documentation practices that should be looked at, or maybe new users have joined or things like that. So really, really focus on delivering high quality data so that it's easily consumable for the end product to use.
Very good. Okay, next question here, moving right along, is how does the Healthjump and health equity program increase patient engagement?
That's a great question. I'll maybe start. I think, so patient engagement, I'm going to take kind of broad term. I think patient engagement in the practice and in their own preventive care, one of the big drivers of that, like you can imagine how frustrating it might be for a physician in a clinic to say like, hey, I'm getting information that this HEDIS measure is open or that HEDIS measure is open, like let's come up with a plan to close it. And the patient says like, hey, I had a mammogram last year, like leave me alone, right? Mm-hmm. So I think just to the earlier question, like high quality data and using that to inform visits, like is a great way to keep patients engaged with their primary care, because they're not having to sort of like question the credibility of information or any of those things. When we think more broadly though about patient engagement, so we actually have a pretty robust member engagement program here at Equality Health. We work with practices to, as we think about their patients with chronic conditions who may or may not be managing them well, or patients who are due for preventive visits or, need an annual well or whatever. We do a fair bit of telephonic and SMS outreach in support of the practice to make sure that those patients are getting in. We want to do more in that space, and that's one of the things that we think, number one, just having access to more timely data, but then also just to go back to scheduling data, like think about how much more impactful it is to be able to outreach a patient and not say, based on this data that's 3 months old that I just got from claims, I think this may be going on. But to instead be able to say, hey, you were in the hospital last week, or I have your new A1C from your visit yesterday, and here's something that we should talk about. Or to be able to say proactively, like, you're going to see your provider at Sun Lakes tomorrow. Let's you and I spend some time talking about things you want to make sure to cover with the provider. Like, it looks like this is going on. Let's make sure we talk about that with the provider. It looks like that is going on. Let's make sure to talk about that with the provider. So it just totally changes the game in terms of building trust with members, and particularly our member population. Just being able to demonstrate a more timely understanding versus waiting for claims and then having to like, so tell me everything that's happened in the last 3 months, because I don't have any visibility into that because the claims aren't processed yet. Like, it totally changes the conversation.
Great answer. Okay, moving right along. This question is for Nikki. Can you share some comments your member physicians, let's see, your member physicians are saying about the Healthjump Health Equity Service?
Well, they don't say a lot about Healthjump because it works in the background. So that's less that they have to do. It's not a pop-up on their screen where they have to answer all the questions A through Z to submit back to the payers. So it's just taking that information on the back end, submitting it on their behalf, or providing it on the front end in lieu of chart preparation.
Yeah, and even on the equality health side, Nikki's exactly right. I think even on the equality health side, we work with our provider partners and with physicians specifically, but increasingly the work that we do is not actually with the physician, but with the staff, right? Like, it's not our goal that a physician is logging into Care Empower like alongside their EHR as part of a 9-minute visit. Like, that's just not, it's not realistic, right? And any portal that aims to do that, I think is maybe off the mark. So we think more about our key workflows as designed for the scheduler, for the medical assistant, for the practice administrator, to kind of oversee how patients are sort of coming in and how that can sort of happen proactively in the practice, so that the physician is seeing a patient and like not having to deal with the rest of it. So I love Nikki's response that like, they don't talk about it. Like, great, that's what we want.
It's good news, yeah. No news is good news, right? Great. Okay, well, we have time for one more. Oh, actually, we had a couple more questions that have come in. Okay, this one is kind of an interesting question. It says, if I'm understanding correctly, in line with the value-based system is a strong reliance on accuracy in data input, which in turn, suppose AI can develop to the point of taking over for humans handling the data input. I say this because current human data input is running about 65%. Please enlighten me. Love the webinar.
That's
So I don't know if what the question is there, if it's a comment or if you're.
Yeah, I think it just reinforces, I mentioned early on when we were talking about how do we frame what we want a relationship with an EHR partner like Healthjump to look like. And the ultimate answer to that is, let's stop asking practices to do low value work and instead ask them to do sort of the most important work, which is like the engagement of their patients, the proactive engagement of their patients, the sort of that actual interface with the patients is the thing that's most important. The thing that's not super important and doesn't add a ton of value, whether that's because it's just manually intensive, or because ChatGPT is gonna deprecate us all in the next 5 years, is the documentation, right? And so, I think the more that we can do to just reinforce that, like, what administrative work in practice is valuable and what administrative work in practice is not, and how can we as partners to primary care providers like not ask them to do the low value stuff anymore, That's really where we're going. And so I don't know if that's like a direct answer to the question, but that's how we think about it.
We did some data collection and information, and a fun statistic kind of on that note was that in a year it takes 3.4 humans or administrative people to do the job of submitting that data within Equality Health and its payers, and we've brought that down to 1 with the time savings. So
that's significant.
3.4 humans.
Yeah, that's pretty significant. Yeah, that's great. Okay, next question here is, what are some of the cybersecurity protocols being followed for EHR implementations? I
can take that. I think that's probably pointed at Healthjump. We at Healthjump take our security to heart. So we have high trust certification. We follow HIPAA. We have SOC 2 through our environment with AWS. We're fully cloud, which helps with a lot of that. And we go through routine security audits, et cetera, as well. And so we have a security officer that keeps up on all of that and implements all of those processes and provisions. Is encrypted in transit and at rest, which is kind of the key thing to know in terms of data security itself. And then, from our partners' perspective, they hold us accountable. So I don't think we have a single customer that hasn't put us through the ringer in terms of security questionnaires on a routine basis to make sure that we're up to, their standards as well, if not beyond.
Yeah, no, that's great. Okay, next question is actually a follow-on to the previous question, same individual, and they say, thank you, Claire. Sorry about that. My field is AI, and we cannot continue a 35% error, okay, for certification. They said, thanks, Nikki, for the interesting stat. So it'll be interesting to see what happens as AI continues to develop, for sure, and how it implements here. Okay, that is actually all the questions that we had come in today. So we're going to wrap up a little early, which is wonderful. Thank you, ladies, so much for the presentation today. This was fantastic. I know I learned a lot, and I'm sure the audience did too. If you have a question out there that you're wanting to ask, you can either go ahead and submit it now, and someone will reach out to you, or feel free to reach out to us. As we conclude, I'd like to encourage you all to go over to vbcexhibithall.com and check out the Healthjump virtual booth there. And that booth is kind of a living, breathing brochure that is what they're doing in the value-based care space. There's a lot of great resources there. You can really read up on them, learn a lot about what they're doing, and interact with the team there. So a lot of great stuff there at vbcexhibithall.com. And then finally, if you would like to reach out to our speakers or to Laura or myself, you can do so. I'm happy to facilitate an introduction as well to them and put you in touch. Or if you have an RFP that you would like to submit, I'm sure they would love to receive that as well. And so you can reach out to them there. And thank you all again so much for coming today. I know Claire and Nikki are both in the Phoenix area, and so it's extremely hot in about 117 today. So thank you for joining us in the heat. And so we hope that you stay cool. Thank you all for joining us. We'll see you next time. Have a great rest of your days.
Thank you.
All.
Bye-bye.